Hi, everyone. Welcome to the Trial Site News Podcast. I'm Dr. Erin, your host. And today we are going to be talking about VAERS, the Vaccine Adverse Event Reporting System. My two guests happened to write an article on this topic. It's a hot topic. Everyone's talking about it. So thank you so much, you guys, for joining in on the Trial Site News Podcast. We have Dr. John Rizk and Dr. Jack Lewin. Thank you guys very much joining in on a Saturday. My first question, do you mind just taking a few minutes to introduce yourselves?
Yep. So Jack Lewin, I'm a physician, kind of an eclectic career of kind of serial CEO, ran the American College of Cardiology, the California Medical Association, was Hawaii's Director of Health, Commission Officer, U.S. Public Health Service. More recently, the Cardiovascular Research Foundation here in New York at Columbia University. But I have been a public policy person involved in many research activities throughout my career. And I'm also chairman of the National Coalition on Healthcare in Washington, trying to keep Congress on track, which is a very difficult job with health policy.
I'm John Rizk. I'm a pharmacist by practice. I'm also a researcher and currently doing training in pharmacoepidemiology and drug safety at the University of Maryland. Glad to be here.
All right, glad to have both of you guys here. So VAERS, it's a national vaccine safety surveillance program. It's a passive surveillance program, but it's used to detect adverse events after a vaccination. So can you first talk about how a potential safety signal is detected or a pattern of adverse events?
Sure. So a potential signal is detected when somebody reports it. So anyone can report to VAERS, and the system relies on physicians, patients, manufacturers, caregivers, so basically anyone to report adverse events that are possibly related to the vaccine. Now, these adverse events may or may not be causally related to the vaccine, and by including all the health conditions that occur around the time of vaccination, VAERS can look for new or previously unrecognized health events or very rare conditions that people may not have associated with a vaccine. And there's a pattern of reporting, but unfortunately, it's a very inconsistent method of reporting, I must say. And there's really no guarantee that people are going to voluntarily send information to VAERS. And with that, I think that the system is undoubtedly missing data of adverse events.
Okay, and that's kind of a perfect lead into my next question, which is, what are some of the main limitations of VAERS?
Yeah, I'll grab that one. Well, I mean, I think part of what John just expressed is the biggest limitation. Anyone can report to VAERS, so we don't really have, a scientific basis beyond a lot of the reports. People may be could be having symptoms that are unrelated to a vaccine, but they might have a muscle ache, they might have a headache, they might have anything. They can, if they're worried about it because they were vaccinated recently, they can report it. Similarly, reports come in without a whole lot of maybe scientific background attached to them, and that's part of the issue. So let me just but I think we should, in the first view of this, is VAERS is great. I mean, thank goodness we have it. We have such a national system. We need it, and it's way better than having no system. But the limitations have to do with the quality of the data coming in. By the time we go back to a medical record and look at the actual medical background information to confirm or to further substantiate with laboratory and other kinds of diagnostic stuff, that material doesn't get reported back to the public. So the original stuff that comes in is publicly viewable. One of the other limitations is it takes weeks for that to get published. So you're behind the times by at least a month and a half by the time it gets published. So, it's great that we have it. It oftentimes has junk information in it that hasn't really been purged because somebody hasn't had a chance to really review all the stuff. But somebody is doing that. There is something called the EPS version of VAERS, which is the Epic system program version, where there's background material and a lot of medical records analysis done to try to understand the reports that come in. Again, it's all de-identified, but there's a public health purpose for going back and finding that data. But unfortunately, that doesn't get reported. So, that's information that gets interpreted later by CDC, perhaps in most cases. So in other words, it's a reporting system. It has a lot of elements that could be improved, and we'll talk more about that as we go on.
Thank you. So you mentioned VAERS relies on voluntary reporting. Is there any data on whether underreporting or overreporting, or maybe both in some cases, is a problem?
Okay, so I can get that. There's no data on that, but what we know anecdotally is that there is a problem with both, as you say, overreporting and underreporting. So overreporting of common resolvable symptoms, like Dr. Lewin mentioned, like headaches or injection reactions, and underreporting of severe complications, possibly because people haven't made the correlation yet between a medical occurrence and its association with vaccination. And one example is VIT with CVST, which is vaccine-induced immune thrombotic thrombocytopenia with cerebral sinus venous thrombosis. So those are stroke-like symptoms of a typical thrombotic form that occur with low platelet counts. And during the earlier phases, we didn't know if there's a common complication because there weren't enough reports, and because it's likely that the stroke centers in the US didn't report all the time because they weren't sure if that is a complication of vaccination or just a stroke from other reasons. This could have been a situation. Doctors weren't instructed to report to VAERS because it wasn't felt to be related to vaccination. So if you're looking at people who have no reason to have a stroke, those are totally healthy people with no high lipid levels, no hypertension, and then had a minor stroke that appears on an MRI. Could that be related to the vaccine if it occurred within a few weeks of vaccination? We didn't have enough data to this.
Yeah, and I think there's neurologists that I know here in New York City that think they saw some strokes that occurred in people without any apparent risk factors. Younger people with normal lipids, no signs of atherosclerosis, no hypertension, no reason to have a very small stroke. But so we don't know about things like that. With something as significant as the venous sinus thrombosis, where it's a dramatic impact. Okay, but one of the things that comes out of VAERS with that particular diagnosis is that in the general population, we would expect 2.4, something like that, out of 1 million people to have venous sinus thrombosis. Very infrequent, but there's a kind of a medical history to say that's what's there. With the AstraZeneca vaccine, we saw from all those who were vaccinated, we saw a higher number of around well over 3 per million, and with the Johnson & Johnson, it was somewhere around 1 per million. So that's there. But here's what really jumped out at people looking at this, is that for people who were hospitalized with COVID, then the number of these complications was well over 200 per million. So a much higher number than what would be expected in the general population. So thank goodness for VAERS. And and hospital reported data is likely to be much more reliable than what happens with other reported data. And since some physicians don't bother to report, others might over-report, and patients might not understand what they're reporting, even though they're trying to do the right thing. So that jumped out at VAERS. We knew that something was really going on here with vaccinated people because of those high numbers.
Thank you for that. So you guys mentioned that anybody can, file a report with VAERS. Is there any data on who's doing that? Or is it mostly healthcare workers? Is it lay people who feel like they might have had a reaction? What are your thoughts on that?
It's mostly doctors and healthcare workers, nurse practitioners, physicians, people who are on the front line of healthcare who take it seriously. Because it's a voluntary program, it's a concern that there's no look back. There's no way to enforce it, to say you should have reported something, unless a patient goes in the hospital with an obvious complication related to vaccination, and then you go back to the doc and say, why didn't you report this on the way in? But in other words, I think the system, because it's voluntary, has some defects, and we could talk more about what we think should happen to improve the system over time.
Absolutely. No, that's interesting, because that's a big question in terms of who's doing the reporting, because some people will just dismiss VAERS. And I'm really glad that you said, thank God we at least have it, but we have to make it better.
Mm-hmm.
How do you guys think VAERS is performing during the COVID-19 pandemic? We have new vaccines out there. What are your thoughts on this?
Well, as Dr. Lewin was saying, it's good that we have something, but we could also need to have something better. And despite the well-known limitations of VAERS that we mentioned, we can't deny that VAERS has shown to be a model of transparency during the pandemic and is essential for ongoing monitoring of vaccine safety, especially the rapid detection of rare and severe side effects. And we touched on VIT with CVST, which was an issue with adenoviral vector vaccines like Janssen. But we can also add to that the adverse events reported from mRNA vaccines like Pfizer and Moderna, particularly myocarditis, which was also detected during the earlier phases of the rollout and was reported to be more prominent in younger males.
Mm-hmm. Very, very, very true.
So my last question is kind of the biggest question here. You guys wrote a paper about this. What are some recommendations for making VAERS better?
Okay, well, I think John, jump in here. I'll try to run through these things, but your comments would be helpful because we did this together. But I think that we think that the surveillance systems, first of all, have to be improved. We need increase the utilization of vaccine safety surveillance systems, and there are other systems out there that are being used in the process. But we'd really like to have access to electronic databases, hospitals and clinic charts, electronic health records, and that information can be pulled, and it can be pulled without compromising people's privacy. And so we should be doing that more often, and including that background information in what we report to the public, because it's going to be richer, and it'll not only improve the estimates of numbers, but the incidence rates of adverse events. So that's the first thing. The second is we need to support surveillance in lower income countries, because look, this is a worldwide global epidemic. Why don't we, Europe is doing similar, has their own VAERS program. EU does, and there are comparisons running, and there's the CDC is working with its counterparts in other countries to make these kinds of global comparisons. But we really ought to be thinking about a global system that actually allows lower income countries to report, and we should be subsidizing that. The countries that can afford it should be doing that. So that way we would have much more data and much better data, and particularly with ethnic subgroups and various populations that may not be covered. We want to make sure that non-electronic data can get collected too. There are things like optical character recognition technology and natural language processing technologies. So we could be pulling in faxed information and printed information from places where they don't have the ability to report electronically and still interpret it with new technology without having to have minions of people reading all that documents. It could be scanned using new technology and artificial intelligence. And why not? Why not facilitate a better data collection when it's not electronically available around the world? The fourth thing is we want to improve the vaccine-specific data collection in terms of filtering and processing adverse events based on the vaccine type, so that we really have, and also with populations, with sex, age, pregnancy, all that sort of stuff, history of immunodeficiency, for example. These kinds of things would be really important for us to be able to see earlier in the process, and may not come in with an individual's self-reporting. So this is really important to do to get more of the specific data that we need across surveillance systems to evaluate potential safety signals earlier. We would like to see, fifth, the improvement of data interoperability. There are lots of people with different systems out there, and the reporting processes. This is true of everything in healthcare. We always talk about interoperability, and it's like Groundhog Day. We never get there, or we go back and talk about it again next year. So let's get there, because this will greatly facilitate our ability to go through all the information that comes in and have it come in from so many more sources. We would like to enhance the follow-up for patients and through their clinicians to find out what happened and what's going on. Is this adverse event a very short-term thing? And we were looking, most of these events were, came in terms of this venous sinus thrombosis. It happened between 5 days and 40 days across the reporting process. What happened after 40 days? And what was going on before the fifth day when people were failing to report? So we'd like to know more about the clinical follow-up and longitudinal follow-up data to include in reviews of the VAERS reporting data for a particular vaccine-related event. The seventh thing is to improve the regulatory and public health collaboration, because the regulatory authorities and CDC and the public health agencies really have their own interoperability problems and their own vaccine-related consistency problems. And so that really slows down interpretation and clarity of communication, and doesn't really facilitate accelerated data dissemination. So we'd love to see more collaboration between the regulatory and the public health side of the reporting processes across the country here and globally. Eighth, interregional data sharing. We'd like to see, for example, what's going on with vaccine, whether other adenoviral vector vaccines, had similar results. We weren't looking at Sputnik vaccine or some of the other lesser used vaccines weren't included in the process. So we really needed to pull all that data into to see what other events might have been related, and then try to understand the pathophysiologic underpinning of the adverse event with respect to the different mechanism of actions of the vaccines out there. We think there's a lot that can be done to enhance the accuracy of the data. We talked about that earlier in this, but completeness and accuracy of information from initial report, the idea of getting into the EHRs immediately and trying to understand more of the vaccine type, the date of vaccination, the patient history, all the demographics, and and so forth. We can do a lot there. And finally, just improving data transparency and provenance. Where's the source of the data? How reliable was the source of the data in the first place? And are we very clear about where it comes from, and including the application of some cases of data that went through data and analytical methods, or there may have been assumptions attached to the data, which may be false. So it's central to public confidence to be able to really understand where it comes from and how transparent we might be about that, so that we're not getting bad data or even, people who wanted to promote something negative could be reporting something in a way that would skew our understanding of what's going on with vaccinations. So, there's no way to stop that if a whole bunch of people went social media wise decided to report something that really wasn't happening. So anyhow, these are things that could take what's now a wonderful resource, VAERS, and make it a fabulous resource. And we'd like to move in that direction, and we'd like to invest in helping other parts of the world catch up with what we're able to do here, because all of us will benefit from that knowledge if we expand this to a global process.
I mean, I just want to say those are great recommendations. When I read your paper, I was like, man, it's too bad these weren't in effect, at the start of the pandemic, because when you tie in the public's trust, there's so much conflict over how one interprets VAERS, and you have like two extremes. Some people are like, this is fact, and then other people are like, oh, it's VAERS, anybody can respond. But you're right, we should go back to, the people who created the system and how we can make it better. I mean,
and take a little less of the voluntary and get a little closer with, let's impress upon doctors and nurses and health professionals the importance of reporting more frequently than less frequently. And let's look back. If somebody comes in, they're hospitalized with some interesting issues, let's look back to the clinicians who took care of them and say, why didn't you report this event when it was happening, when you first detected it? There's a lot we can do, and frankly, we could just enhance the whole thing if we follow the recommendations we recommended there. Many other public health leaders I've talked with have expressed similar views.
Yeah.
So we all know that for the next time, let's get ready to do it better.
And I wanted to ask you, Dr. Lewin, a question. When you said why sometimes a healthcare provider might not report it to VAERS, is it just when I went on to VAERS, I found it tedious and it just wasn't user friendly to me. And doctors, nurses, like nurse practitioners, everybody's been overworked.
Exactly.
So is it just? It's not like deliberate. I feel like it's just.
That's the number one reason, Erin. You've really hit on it. It's truly a situation in which we already have too much paperwork.
Yes.
Practicing medicine today is you practice with your back to the patient so you can type information into the computer. I'm afraid that's not really great, physician-patient relationship kind of style. Yeah. But at any rate, yes, it's a bit of a hassle, and so and somebody could just move on and forget to do it because you're dealing with the next emergency.
Right. Thank you guys both so much for coming on. To our viewers, thanks so much for tuning in. Leave comments, share, subscribe. Always enjoy reading them. And if you guys have any other research that you want to come on and present, or any updates about VAERS, I hope the right people are listening and, hopefully get some of this stuff implemented for the next time. I don't really like saying that, but probably will be a next time. Yeah. Thank you, guys.
Thank you, Erin.
Thank you, Erin.
All right. Enjoy the rest of your weekend there.
Thank you.
Bye-bye.